Assalamu alaikum wa rahmatullah. Hello everyone. I'd like to start this afternoon session, and it will cover some spine trauma, and we'll start by thoracolumbar fractures management strategy, which will be presented by Professor Masato Tanaka from Japan. Dr. Masato.
Yeah. Thank you, Chairman. Good afternoon, dear colleague. My name is Masa from Japan. Today's my topic is about thoracolumbar fracture. This is my COI. After this lecture, you can understand the precise surgical indication for thoracolumbar trauma. You can have a knowledge of various kind of surgical technique, and also you can update of MIS technique for thoracolumbar trauma. This is the context of my talk. First, I would like to mention why we need classification. So there are a lot of classification. The first one is historically important, Holdsworth 2 column theory. This is very simple, but too old, as you know. Then is 3 column theorem. This is very important. This is very simple. However, he didn't put any instability of the spinal column. Allen and Ferguson, this is very famous for cervical trauma, not thoracolumbar, but they concentrate the mechanical. McCormack and Gaines, this is a point system, and it includes clinical result. However, they don't include any neurological deficit. AO classification is now world standard. It basically on the morphologic change, and you can understand the severity and instability as well. However, it's a little bit complicated to remember. TRIC system is also a point system, but liability is not so sure. Some doctor asked you, how do you decide surgical indication for thoracolumbar trauma? Young doctor said, of course, I know it's very easy. We use TRIC score. According to TRIC score, thoracolumbar injury classification and severity score, it includes morphological change and neurological involvement and posterior ligament compress. This is very important. So more than 5 is an indication of surgery. Everyone knows this classification. However, not so simple. If you look at this one, L1 burst, 33 years old male. Maybe you think about the surgery, but if you check TRIC score, burst fracture is just 2. Luckily, he has no neurological deficit. Posterior is intact. This is just 2. This is not a candidate for surgery. You agree? It's not so simple. So the second topic is treatment strategy for AOA. So as I said, AO classification is now world standard for treatment. Type A is compression injury. Type B, destruction. Type C, translation. So about 2/3 are type A. So from type A0 to A4, A0, minor fracture. A1, wedge compression. These are mainly for non-operative, conservative treatment. A4, complete burst. Everyone think about surgery. A2, split one. A3, incomplete burst. These are controversial. So even though A1, young patient, compression fracture with kyphosis more than 30 degrees are supposed to be stable and can be treated conservatively. But this means more than 30, you should choose surgery. More than 15 degree kyphotic deformity is the operative treatment in German society. I'm not sure this is correct or not. And old patient, of course, you can choose another option for percutaneous vertebroplasty or balloon kyphoplasty. Now, Japan is suffering from graying of society. We have a lot of this kind of patient. We sometimes use BKP, balloon kyphoplasty. A2, split fracture, also called pincer fracture. Usually, non-operative early mobilization is okay. However, wide fragment separation and relevant region of intervertebral disc, sometimes disc is into the fracture side like this. This is high risk of non-union. That's why sometimes we do this kind of percutaneous screw fixation. A3, as I said, it's a controversial. So more than 15 or more than 10 degree kyphosis or scoliosis are the candidate for surgery. So AO spine trauma knowledge forum. So AO spine famous guy gathering and then decided the knowledge. So neurologically intact one, even though A3, it's maybe posterior surgery. And neurological deficit, you choose surgery, posterior. Intact one is controversial. Some doctor choose posterior surgery, but some doctor conservative. Let me show you our technique. It's a CM-free navigation technique. First, under navigation guidance, without CM, we put pedicle screw, percutaneous pedicle screw like this. In Japan, we are so much afraid of radiation exposure. Radiation-induced cancer. Compared with trauma, so leave a very small amount of radiation, but the body is too much. After putting this, and then percutaneous reduction with a CM. AO4, usually surgical intervention is recommended, especially anterior and posterior like this. Thoracolumbar, if you are not so sure, 2 above, 2 below is better. But for lumbar region, 2 above, 2 below is not a good idea. You should preserve motion segment. I mean, 1 above, 1 below. So sometimes we do this kind of MIS mini colpectomy. Just 5 centimeter small skin incision, and then remove the rib, and then I always use navigation, and then navigated instrument, put a cage. Nowadays, expandable cage is also navigated like this. And I already use neuromonitoring for sure. So next one is AO, B and C. AO B1, it's actually we call chance fracture. According to the textbook, chance fracture should be conservative treatment, but sometimes we need surgery. So B3 is hyperextension. This is controversial, but usually operation. B2 is definitely operative. So B1, mechanically unstable fracture. Sometimes. No neurological deficit, conservative treatment is appropriate. Immobilization in a cast or TLSO can be performed. If the patient don't want to wear those, percutaneous pedicle screw fixation is another option. In Japan, they don't want to wear the hard brace. This is 23 years old A1 chance fracture with the percutaneous fixation. A3, as I said, it's a controversial, but usually this fracture type is commonly seen in patients with ankylosing spine or diffuse idiopathic skeletal hyperostosis case. In those cases, long segment posterior instrumentation is necessary. According to the textbook, 3 above, 3 below. But nowadays in Japan, 2 above, 2 below. Do you know the reason why we use transdiscal screw? Very strong one. This is a result. This screw is penetrate the disc. So that's why this screw pull out strength is, if you look at this, 1.6 times stronger. So this means 1.6 plus 1.6 is 2.3, 3.2. That's why the same of the 3 above. Of course, augment screw is another option. But you have to use C-arm for augmented screw. But this transdiscal screw, you don't have to. C-type, absolutely unstable, so definitely surgical indication. 2 above, 2 below. And you should remember, type C, more than half are complete paralysis. Asia A. This is 35 years male, so T8, 9 fracture and dislocation. We perform 2 above, 2 below. Last one is a very unique case. So 18 years old female, this is suicidal jumper's fracture. So in this situation, it's a high energy trauma. So the rib fracture and another spine fracture. If you look at this, 1, 2. So there are several fractures, multi-trauma. So injury severity score is 20. This is a severe state. So, and of course, rib fracture. So according to the indication, so this is a TIC score more than 5. And if you look at this, for trauma guy, understand this is the candidate for surgery. Reconstruction of pelvic ring is necessary. And reconstruction of T2 burst fracture is necessary because fragment occupying ratio is 50%. We perform MIS. Put screw like this, and then pelvic screw. This is pre-op, this is post-op. Take home my message is AO classification for thoracolumbar trauma is very important classification. Anterior approach is indicated only for severe burst fracture, A4. More than 5 of TRIX is indication for surgery. For anterior approach, MIS corpectomy is becoming very popular all over the world. Thank you for your attention.
We will allow 2 questions for the professor. Tarek.
Yep.
Thank you for
Yeah.
my question is regarding the transdiscal screw
Yes.
used in AS and dish, right?
Mm-hmm.
There is some biomechanical study showing the efficacy and superiority,
Yes.
etc. Do you use it in every patient with AS or dish? I mean the syndesmophitic. We have 2 types of AS: syndesmophitic and non-syndesmophitic, where the disc is not yet very well ossified, and the one with the disc is totally calcified and ossified. There is any difference to use these screws, the transdiscal screw?
Yes, any difference because it's an ankylosed spine.
Yes.
So you don't have to worry about the disc. Already fused, right? So disc is not ossified or calcified. So the ligament is already, and joint are already fused. So you don't have to worry about that. Just to put a screw.
Thank you.
Dr. Tanaka, thank you for the presentation. Regarding you use always navigated percutaneous screws.
Yes.
So your decision after bone healing, you remove the construct or you leave it inside in most of your patients. You managed, but you said in Japan they don't like braces.
So
So you use to fix all types of fractures.
Yesterday, you
Construct removal.
asked the same question. So as I said, instrumentation without fusion, usually we have to remove the instrument. So for the just A3 and then reduction and percutaneous, so about maybe 1 year later, we remove. But so corpectomy, we do anterior fusion. Without posterior fusion, we don't have to. Just leave it alone. And for elderly patient, so 2 above, 2 below, so if the patient have some problem, like protrusion of the implant, I remove, or loosening of screw, I remove. But sometimes, say patient never complain about this complaint, I don't want to remove, because for elderly patient, another surgery is a risk for the patient. Thank you.
Thank you for the recommendation regarding the anterior fusion. You are not in need to remove it. And the posterior fusion, you have to remove it, especially if it is just fixation. If it's fixation, it has to be removed to save the facetal joint. Is it right? What is about anterior? Why you didn't remove the anterior plate, which is fixing 3 vertebrae together, including the prosthesis in the middle or the graft? Is it because it is difficult or vascular problem? Why you are insisted to remove behind and accepting the presence of the implant forever anteriorly? Because the segment is short, what is the reason? You have to give us the advice, please.
Maybe you don't know the truth. We perform a lot of anterior plate, Canada device. So, but now we are suffering of graying society. We have a lot of elderly patients, so osteoporotic patient. Anterior plate is not working. So in Japan, anterior plate or anterior fixation, nobody do. In the world, I attend a lot of meeting, but anterior plate, I've never seen that one. But Egypt, maybe young patient, sometimes okay, but biomechanically saying, so posterior pedicle screw is much more stronger. Thank you.
Thank you. Thank you.
Transdiscal? I never remove. And other indication for transdiscal is L5, L5 high-grade spondylolisthesis. You can put, this one is original for transdiscal screw.
Okay, thank you. Thank you, Professor. Thank you. Now we call on Professor Vivek Tricha from India, I think, going to speak about sacral fracture management. Professor Vivek, please.
Thank you, chairpersons. I might be the only trauma guy in the gathering of expert spinal surgeons, and I'll be speaking on the sacral fractures. My learning objectives will be to learn and diagnose how to diagnose the sacral fractures, discuss the different treatment options which are available to us, and also how do we find out the right treatment modality for a fracture pattern. First of all, why sacrum fractures are important. That's a force transfer between the axial and appendicular skeleton. And most importantly, even if there might not be any neurological problem, the malalignment impacts your gait as well as the limb-limb discrepancies, which can cause a major factor. Usually, sacral fractures can be undiagnosed in a pelvic injury. If you look just at the X-rays, 51% were undetected. And as a trauma guy, whenever we have a pelvic injury, you need to think of a ring or a bangle. It has to break, bangle the wristbands, if you can say. So the bangles always will break from two sides, or one side will deform if the other side breaks. So always think of that. If anterior pelvis is broken, there has to be some injury on the posterior side which may have an effect. Radiology, as we know, is the major thing. When you get in a trauma series, a pelvis X-ray, and you find a minor displacement anteriorly, always and always look for a posterior injury by a CT scan. Dennis classification for sacrum, it's one of the most cited papers, just gives us anatomical variations of where exactly that fracture is, lateral to the foramina, through the foramina, or medial to it. But it doesn't tell us anything regarding the displacements, stability, or when to fix them. The other classifications which are required out here will be the dislocations part of the spinosacrum of Roy-Camille classifications, which gives us the instability and the displacements with the risks involved of neural deficit. And very importantly, the facetal joint of L5S1, the Isler's classification, which denotes which fractures will come into the domain of the spinal surgeons, if I can say, and the trauma surgeons. As was being told by Professor Tanaka out there, this classification has also been given by the sacrum fractures by Eospine, and it also defines and divides into three major parts. One is the transverse fractures, the A type. The B types are what we as trauma surgeons normally deal with, which is the posterior pelvic injuries. And the C types are the spinopelvic dissociations or the instabilities which we want to look at. It can also look at the neurological problems. It has got some modifiers and the soft tissue problems, which many a times occur in pelvic injuries and more commonly in the sacral fractures. Coming to management, complex, controversial. Why is it controversial? It's because their problem and a tug of war comes in no man's land. The spinal surgeon says coming in pelvic trauma, and the pelvic surgeon says, or the trauma surgeon says, it has to be treated by the spine. And both of them leave it to the other person to define when to treat it. If it comes to a trauma spinal surgeon, a spinopelvic fixation is most commonly done. If it comes to a trauma surgeon, it's a iliosacral screw which is done. So no common ground on which we all can sit together and say which is the fracture which requires what. And that's why we don't have a comprehensive guideline which incorporates management and principles from both. Look at this paper in Journal of Orthopedics Trauma in 2014 as well as 19. Both of them suggest there is lack of consensus in treatment of sacral fractures among the OTA or the US surgeons. What are the indications? Unstable fractures, neurological deficits, and severe malalignments. What are the techniques? I'll be giving you an entire picture of how do we treat the sacral fractures, the iliosacral screws. They form the most common for A-B types. In some cases, in delayed cases which are very relevant to our developing world part, transiliac plating gives us some stability of the pelvis, and there will be some specific indications when the spinopelvic instability where we have to use the spinopelvic fixations. Giving you some cases. Now look, this is a pelvis case who had the lady, 23-year-old, fall from height from the 3rd floor, having a severe resuscitation problem with a pelvic injury. You can see the amount of displacement in the inlet view and the outlet views. Looking at the CT scan, you'll find a highly displaced sacral fracture coming partly through the foramina and going lateral to it. What to do? Is it all for always lumbopelvic? But remember, it's slightly different from the usual spinal cases. When this fracture happens, the soft tissues on the back get damaged a lot. And if you're going in for an open fracture reductions and doing some fixations, the soft tissue dehiscence can be happening. And when it comes to you late and you're not able to reduce it, then it will be an issue. But we tend to go thinking that it is a pelvic injury here. There is no spinal involvement. And I'll show you how this amount of displacements which are there in the limb length discrepancy and posterior displacements you can reduce by giving a paramedian incision in prone position using the reduction tools for this, because your aim is to get a spine complete pelvic ring with limb length discrepancy not being there. And once you have reduced that, then you go in for iliosacral screws, and this can help you with an anterior fixation get the fracture from that side, outlet views and the inlet views back to its position. 5 years down the line, I've just removed her because now she's getting married. She doesn't want any of these things inside. So I just removed her around a year back. Remember, iliosacral screws are a critical gold standard for us, but it cannot be put if you do not have accurate reductions. Just a 5 millimeter displacement in a sacrum can lead to a loss of cross-sectional area by more than 30%. Next comes a transiliac plating, useful sometimes in comminuted bilateral longitudinal fractures. Very commonly done in developing world because can be done even without an image intensifier. Acts as a tension band. Can be used with iliosacral or spinopelvic for that matter. And when the patient comes late to us, which is very common, 3 weeks, 4 weeks, 6 weeks down the line, you are not able to reduce these fractures which have already united. So what do? You cannot put in iliosacrals. Your spinopelvic may or may not give you the things. You have to get about fixing and giving some sort of stability, which a transiliac plating does. Similar sort of fracture which I showed you, coming late to us with a sacral fracture. We do 2 paramedian incisions at the PSIS, cut out a PSIS osteotomy, slide in our plate after reduction if you want that, put in the screws on the ilium. You are relying on the intactness of the sacroiliac ligament and the joint on both the sides to get the reduction as well as the stability, and you can get away by this. Then comes the lumbopelvic, for which you all are here. Yes, it is the best fixation. It gives you triplanar, multiplanar, good fixation and stability, allows early weight bearing, but not necessary that you do it for all cases. It is only when the spinopelvic is there or instability is there, then only you need to go about managing it, or for spinopelvic dissociations in Roy-Camille classification. So the indications will be gross spinopelvic instability, the H and U types, and as I showed you, Isler's classification. You know better where exactly to put them. Anatomical one is the most common, but S2LR iliac, which is so common for you in the tumors, can also be put here. But in trauma, it usually is, the fracture is usually happening where your S2LR iliac screw insertion point is going to be. Showing you a final fracture having something similar to what Professor showed you, but I'll give you something more and add to it. You see the L3 spine, you see the sacrum which is bilaterally dissolved, multi-facet, multi-combinations you can see. Look at the further things. We did it. Sometimes it comes late to us. We don't have navigation in my hospital, so we have to sometimes do it open. And we get about getting the same sort of stability as we want it with the lumbopelvic fixation here. Normally we get it removed at 6 months to 9 months for the prominence part, for nothing else as that thing. And this spinopelvic helps us in fractures like this. 16 or 17-year-old person having an L3 spinal burst, sacral S1, S2 flexion of dissociation, combined acetabular injury, and a subtrochanteric fracture. This is what polytrauma has to be dealt with by us polytrauma or the trauma surgeons. So now what you do for this complicated case, because every reduction is dependent on the proximal reduction of it. If I don't get the spine right, my sacrum and the acetabulum doesn't get right. If my acetabulum is not right, my pelvis is not right, my acetabulum will not get reduced, and then subtrochanteric also needs to be reduced. So spine fracture, spinopelvic, acetabulum, and proximal femur. So here also we had to go it with the long fixations. We went it with a triangular fixation here with the iliosacral screws and the stability of the spine. And then subsequently, we also had to do is acetabulum fixation along with the subtrochanteric fixation. This is what it looked like finally, and after 6 months when the things had united. There can be some complications. Remember, in spinopelvic, you will have a lot of wound dehiscences, and as regards neurology, there is no thing which is controversial. Whether you do a decompression or not is the question. So finally, sacral fractures are different ball game than the regular spine which you get. Various treatments are there, not only spinopelvic fixations. For us, iliosacral screws and iliotransiliac plating form the mainstay for the pelvic injury as such. And whenever it's a spinopelvic instability, then you go about doing a spinopelvic with triangular osteosynthesis. Thank you.
Thank you so much for the presentation. Comments or questions? I'd like to ask you regarding tips and tricks in reducing fracture sacrum with kyphosis below the level of S3 or S2. How you can reduce it, or you simply decompress if the patient has any neurology and leave it like this?
S1, S2, those flexion injuries are easier because when you go and do your spinopelvic at that time with the distraction itself, most of the time this will get retracted and the kyphosis will decrease. For S2, S3, which is below, you need to give you a midline incision and put in with your towel clips, try to reduce them and push your lower fragment because it comes in the transverse category of the type A of your AO spine sacral fractures. There you can use the distraction in a different method, in the sense in a longitudinal method, and put in long vertical plates at L2, at S2, S3 to stabilize them and get the reduction. Many a times you may not get the accurate reduction of that. At that time your aim is to avoid some prominence which can lead to sores and the soft tissue complications which can happen. So minor kyphosis, we sometimes leave it by just deroofing it. But if it is our main aim out there is not to get the best of the reductions if it is coming late, but to avoid the sacral sores which are there. That's
regarding, you showed us three levels of three methods for fixation. Is post-operatively you deal with the patient in the same way? When you allow walking, when you allow partial walking, it differs from construct to construct?
Yeah, definitely, because if you see, the most stable construct is the spinopelvic fixation, no doubt about that. Multiplanar fixation which you are getting. But don't forget that all these patients with a massive spinal injury or the sacral injury are having severe ISS. They are having multiple skeletal injuries as such. So if it is a spinopelvic, you can mobilize them straight away. Iliosacrals and the other fixations, you will have to wait, but many they have concomitant femur fractures, hand fractures and other fractures, which does not allow them to be walking the very next day. So you need to decide that in a polytrauma situation, and in an isolated case, you can have the different rehab protocols.
Okay, Dr. Tanaka?
Yeah.
So usually vertical dislocation fracture. So L5 nerve root are injured, about half. So in that situation, the spine surgeon should involve this surgery, and you put just iliosacral screw. It's not enough. So for reduction and maintain the stability, spinopelvic is the best option, I think. What do you think?
I had my disclaimer right in the beginning that it is a tug of war between the spinal surgeons and the trauma surgeons. So remember, as I said, when it goes to a spinal surgeon, it's all spinopelvic. And the other thing is, I fully agree with Professor that yes, spinopelvic gives you the best stability which you can have. But where I differ from most of the surgeons who are sitting here will be that not all cases require that much amount of stability of the spinopelvic junction, because it's the pelvic injury and the sacral fracture which is getting the more injury and the forces rather than the spinopelvic junction. So though spinopelvic is a very good, reliable source of stability for us, not all cases require that amount of fixation.
Thank you.
Thank you, Professor.
Thank you. Thank you.
And now we'll move to Professor Hussein Abul Ghait. His talk is about cervical facet dislocation. Still could be missed.
Thank you, Mr. Chairman, dear colleagues. Bismillah ar-Rahman ar-Rahim. Facet joint fractures and dislocation represent about 6% of all cervical fractures, and they can be unilateral or bilateral and may be associated with subluxation or dislocation. They affected mostly the lower cervical spine and not upper because of the superior facet of the lower cervical spine has a lower height, smaller anteroposterior diameter, and more horizontally oriented. So the 70% of facetal dislocation usually occurs between C5 and C7. Maybe unilateral facet dislocation account for 70%, bilateral account for 30%, and the majority of the bilateral facet dislocation usually associated with facet fractures. Still, there is an incidence of missing of the facet joint up till now. Yes, fortunately, those cases reported as a case report and small cases or small series of patients. I will present 3 cases with missed or delayed diagnosed with different types or different causes of delay. The first case, this male patient, 35 years old, and the missed for few weeks, and the cause was unexpected causative trauma. This patient exposed to electrical shock and has suffered from the burn at the right side, which is a side of the radiculopathy, so it was missed for few weeks. The second patient was missed because it's a head injury and loss of consciousness and ICU admission. This female patient, 45 years old, and delayed diagnosis 1 month. This is the third patient, female patient, 25 years old, and has motor car accident, but no neurological deficit, just right brachialgia, and the cause of delay was acceptance of improper X-ray. As we see, the diagnosis or the dislocation was C6-7 and was not clear at the X-ray. This 6-7 dislocation of this woman. Okay, our objectives or my objective of my talk to review the cervical spine clearance guideline, to review the clinical and radiological finding in case of facet dislocation, aiming to minimize occurrence or delay or late recognition of facetal joint cervical dislocation. Of course, cervical spine clearance and stick with the guidelines of cervical spine clearance minimize and of the occurrence of delayed diagnosis or missed injuries of cervical spine, and we should again and again repeat this guidelines for our young colleagues and our juniors. Our diagnosis depend on clinical history of mechanism of injury and presence of midline cervical pain and tenderness with restriction of motion. The majority, 70% of facet dislocation, are associated with some degree of neurological compromise. Neurological status, unilateral facetal dislocation, 20% of patients neurologically free, 30% radicular deficits, 20% incomplete deficits, and only 15% could be quadriplegic. Bilateral facetal dislocation is associated with significant soft tissue damage and the higher incidence, of course, of neurological deficits. We should, again, stick with the guidelines and with the basics of how to read and interpret the X-rays of cervical spine to avoid missed or late recognition. The anterior cervical line or anterior vertebral line, posterior vertebral line, and all these lines also can help us to avoid missing of any facetal dislocation. We can differentiate between the unilateral and bilateral according to the degree of displacement. Less than 25 degree of displacement, usually unilateral displacement, more than 50% is of course is bilateral dislocation. And again, okay, this is a very important sign is Po or Pau Tai sign, and it could be detected in the X-ray. Okay, and CT scan, of course, is very important. CT scan should be thin slices, ideally 1.5 millimeter or less. It should include first thoracic vertebra, and protocol include axial, sagittal, and coronal plane. In axial, this is a very important sign called Hamburger sign or reversed Hamburger sign. Usually, the facet joint in axial plane looks like the Hamburger, so, but in the if dislocated, it reverses and looks like the reversed Hamburger sign. Okay? It's clear? This is the Hamburger sign. This is the normal facet, and this is the reversed abnormal or reversed Hamburger sign. And this is one of our cases. This is a normal facet joint, normal or direct Hamburger sign, reversed Hamburger sign upside down. This Hamburger sign, in sagittal CT scan, pear-shaped facet joint, whose inferior articular facets process appears to be set, means pear-shaped on the ipsilateral superior articular process, and this is called pear-shaped facet joint. Locked facet joint result from jumping of the inferior articular facets over the superior articular facets of the vertebra below and become locked in this position. Okay? Reversed Hamburger sign again. This is the normal, and this is a reversed also one of our cases. This another sign called the headphone sign. This is a normal without dislocation, looks like headphone sign, and if a dislocation appears, looks like displaced or asymmetrical headphone sign. This also our patients, this headphone sign, very clear at this section. The MRI is very important tools for diagnosis and also as tools for management, because the disc herniation before reduction of cervical spine account for 80% of cases, and increase in the prevalence of disc herniation after closed reduction up to 50%. And the most of the studies suppose that or recommend that recommend the MRI before the trial of closed reduction. The classifications is well known to jump. Regarding the treatment timing, conservative versus surgical, anterior versus posterior, combined approaches, and in neglected cases, timing, rapid reduction should give the patient best chance for the neurological recovery. Okay, a conservative treatment with closed reduction, but it's associated usually with high incidence of recurrent instability. Surgical treatment is indicated by the pathology present such as disc herniation, neurological compromise, the extent of bony injury. Anterior approach is schistomy, decompression, reduction, grafting, and stabilization, and the technique of reduction using the Casper pens or the interlaminar distractor is well known. combined approach, when concerned about the fracture segment with fixation by one approach appear to be suboptimal, والfailure of anterior approach to reducing dislocation ده كلها indications of the posterior approach. These are cases. The male patient with electric shock is reduced from one approach, anterior approach, with grafting and stabilization. Good reduction. It was easy, no problem. The patient with female patient with bilateral facetal dislocation is operated upon from the posterior by minimal or partial facetectomy and from anterior by discectomy and grafting. Okay. This after clearing up and of the whole disc material and after reduction and fixation. And the third patient also with anterior approach only with good reduction and good results. My take-home message: understanding of both anatomy and radiological anatomy and their interpretation are essential to avoid missing a serious cervical facetal joint dislocation. Conservative treatment is associated with high incidence of recurrent instability and long-term pain and disability. The pathology presents such as disc herniation, neurological compromise, extent of bony injury, and are the factors determine the surgical approach. Still, I have 1 minute. This photo for the first anatomy session in modern Egyptian medicine. This was 200 before. This actually in 1824, and those students were 100 Al-Azhar students, because there was no regular education regime or system in Egypt. So the Muhammad Ali Pasha Al-Kabir has selected 100 students from Al-Azhar school, and this was the nucleus for Egyptian or modern Egyptian medicine. The names of the 100 students well known in our history, and also the first medical mission towards the France also well known for us. Thank you very much.
Thank you, Dr. Hussein, for the presentation. Dr. Mazi.
Thank you, Professor Hussein. This nice presentation, and these neglected cases well managed actually. But in case you find the anterior approach with discectomy and diffusion, still you can find little malalignment. Say you can successfully reduce by excising the disc and even getting a partial excision of the end blade sometime to make life easy and put graft. But sometimes, in case you find still a little bit kyphotic or feel unstable, do you think we can go posterior and add fixation?
Of course, yeah. We have indication, still we have indication for posterior approach and for combined approach. And we go to 3 approaches, yes. Posterior, anterior, posterior, or the
this
reverse.
For the delayed, so
yeah,
delayed.
Of course.
These
of course.
Stiff cases have to be combined. Thank you.
Thank you very much.
Dr. Tanaka. المايك يا أبو حميد.
In Japan, we seldom use anterior approach because for severe paralysis, so the patient needs tracheotomy. If you put the plate anterior, it's a high risk of infection. Number 2, so usually the facet is locked from anterior, sometimes very difficult to reduce. But if you choose posterior and the pedicule screw, very strong one, so you just remove the tip of the facet joint and then reduce. And it's not necessary to put the bone graft anterior. We choose only anterior for vertical compression type. Only this one. Other one, always posterior.
Yeah.
Thank you.
Thank you very much for your comment. But in cases with huge anterior disc herniation, and if we try to reduce it from posterior, no harm or no risk on the cord?
I can understand, but there is a lot of paper.
So from Dr. Abumi. So even though the disc is herniated, so if you reduce, the disc is also. And then if it's not acceptable, second, you take MRI, and then after that you should. But in my case, very, very rare. Thank you.
Okay, thank you very much. Okay, thank you, Mr. Chairman. Dr. Tariq?
Thank you very much for your outstanding presentation.
Thank you very much. Thank you.
And I believe in many cases, your success depends, just you are lucky, okay? If you succeed to finish,
الحظ راح يبي خلاص دلوقتي.
if you succeed to finish the whole job from
Yeah,
front, that's fine. But in our practice in this country, we still face a lot of patients with neglected one. Some people said, and this is according to maybe our small experience, the most predictable thing is to use the triple approach.
Yeah.
Front,
back,
and front.
Yeah.
If you have a disc, I totally agree with you. If you have a disc herniation
should
from the
exercise
front, it's
it
very
before.
dangerous to go from the back.
Yeah.
What's your opinion regarding the triple approach? It's too extensive, but do you have an experience with that?
Thanks for our
Front, back, front.
Always by two approaches, double
Okay.
approaches.
Okay.
It's achieved in double approaches, not triple.
Thank you.
Alhamdulillah. Okay.
شكرا دكتور حسين.
Yeah, it is the good idea, but we should keep under vision the skull traction to avoid any. Yeah. Okay. Thank you.
Thank you,
Okay.
Professor. Now we call on Professor Ashraf Ismail. We're going to give his presentation on atlantoaxial injury.
بسم الله الرحمن الرحيم. السلام عليكم. النهارده بسم الله ما شاء الله العدد غير امبارح خالص يعني. نعم. امبارح كان اكتر. يس. اوكي. النهارده هنتكلم على الاتلانتو اكزيال سباينال انجريز. The anatomical foundations do advanced surgical management. بروفيسور تاناكا اتكلم على الاوكسيبيتو سيرفايكال انجريز. دكتور وفا اتكلم على ال C2. نعم.
هتكلم بعد دي.
على C2 injuries. فالحقيقه مش عارف انا هتكلم على ايه. learning objectives فيها review complex anatomy and analyzing the classification systems, implemented evidence-based diagnostic algorithms, and application of appropriate surgical and non-surgical treatment. الكلام كده هيبقى طويل جدا طبعا. Epidemiology for upper cervical injuries, the causes road traffic injuries 42%, fall from a height 20%, and war injuries 16%. For male 81%. The surgical anatomy review, the occipito-atlantoaxial complex, actually it is unique in the vertebral column. Unique in both the osteology and ligamentology and the biomechanics also. It supports the large cranial mass. Actually, the joint is between the skull and the vertebral column. It is like a ball and joint mechanics. It allows range of motion, wide range of motion, flexion and extension, axial rotation. Here, as we see, and as we know also, all of us, the C1 is the atlas. It's composed of the anterior arch, posterior arch, and the lateral masses. and the transverse processes with the important, the foramina transversaria, and the posterior arch with a groove for the vertebral artery. For the second vertebra or the atlas or the axis, the most important part of the odontoid process or the dens, which is actually the body of C1. It articulates anteriorly with the posterior surface of the arch of anterior arch of C1 and posteriorly with the transverse ligament. It has also two lateral masses, two big lateral masses with upper surface articulating with the C1 and lower surfaces articulating with C3. The ligamentous stabilization or stabilizers are the most important is the cruciate ligament or the cruciate ligament, the transverse ligament, the tal, which is attached to the medial surface of the lateral mass of C1. And it includes the odontoid, the alar ligaments from the sides of the odontoid, and the apical ligament, which attaches the apex of the odontoid with the basion of the foramen magnum, including also the capsules of the atlantoaxial and occipitocervical and atlantoaxial joints. Here is the transverse ligament. Neurovascular relationships, the important part of the basilar artery, which is the upper part that passes through the foramina transversaria of both the axis and the atlas, and it has a tortuous pattern in the posterior membrane of the occipitocervical membrane, and also it is surrounded with a very tortuous venous plexus. The primary motion is the rotation, 50% at the atlantoaxial joint. It has limited flexion. The occipitocervical also, it is about, the occipitocervical about 50% flexion and extension. With plane radiography, we have the lateral view, the open mouth view, and the distance between the lateral masses in the open mouth view is a key for the fracture of the C1 and instability. Here some parameters, the Harris line and a Powers ratio. CT scan is mandatory now to assess the craniocervical junction, the subluxation and focal hematomas, and occipitocervical fractures and dense fractures. With MRI, occipitocervical joint and C1-2 joint, the spinal cord, the craniocervical ligaments, and the prevertebral soft tissue, the prevertebral soft tissues, and edema also. Now, the classification of the upper cervical injuries, a lot of classifications for each level. It should be comprehensive, simple, and reproducible, and based on several features morphology, and it would be in a hierarchical system progressing from least to most, and also taking in account the neurological status. They classified the region into occipital condyles and occipitocervical joint complex, C1 ring and C1-2 joint complex, C2 and C2-3 joint complex injuries. Here is the occipitocervical condyle and craniocervical junction with type A, B, and C, including the separate joint or individual joint bony fracture with no or little ligamentous injury, type B. Also, it has little but still with no translation. Type C is the complete translation, either anterior, posterior, or distraction. The C1 ring and C1-2 joint, the atlantoaxial joint, either it is isolated bone or ligamentous injury with little displacement, ligamentous injury with translation, and also in C2 and C3, C2-3 joint. Here we notice that all the classifications that the Jefferson classification, Jefferson fracture, or the Felding classification, or the Anderson and Alonso classification of the odontoid fracture, الAO الحقيقة I think they included it in it, but I think it is not fulfilled in that classification. As we see here, the occipital condyles, the C1 ring and C1-2, C2-3, and they added also the other modifiers, the neurological modifiers and the medical modifiers. The M1, the injuries at high risk of non-union. M2, high risk of instability. M3, the patient-specific factors affecting trauma. And M4, vascular injuries. For the neurology, as you see, N1, NO is neurologically intact, and N4 complete spinal cord injury, and 1, 2, 3 are in between. NX اللي cannot be examined, and N plus is the continuous spinal cord compression. C1 injuries, it is all the Jefferson fracture, 1922, anterior and posterior arch fractures, 2 to 13% of cervical injuries, 25% of atlantoaxial injuries. The mechanism is axial loading with head injury also with it, another cervical injuries, and 50%, and neurological injuries are uncommon. Here is the mechanism of injury with falling down, and the head hits the object or the ground, with wedging of the occipital condyles in the C1, lending the lateral masses outward and fracturing or breaking the anterior or posterior, or both anterior arch, posterior arch, or the lateral masses, and maybe the tal or the transverse atlantal ligament. Here is the mechanism. The Lendel's classification and finding of 2022, the lateral masses, it's based on the Jefferson classification. Type 1, anterior arch, type 2, both anterior and posterior arches, and type 3, primary lateral mass extending into one arch. The atlantoaxial rotatory instability, classified by Felding, type 1, type 2, type 3, type 4. Type 1, with anterior and posterior of the right or left subluxation. Type 2, the pivot of one of the lateral masses and anterior subluxation. Type 3, both are subluxated anteriorly with ruptured transverse ligament. And type 4 is displacement posteriorly with rupture or fracture of the odontoid process. The atlas fracture treatment, stable fracture, isolated anterior arch, isolated posterior arch, non-displaced Jefferson, are by a collar or halo vest. Displaced, it will be treated with either sublaminar wires and grafting, or occipito or atlantoaxial fusion. And you may need to also they make the atlantoaxial fusion without arthrodesis also. Time. Axis fracture. Axis fracture for Professor Wafa.
لا go on.
orthodontoid.
أنا مش هتكلم على fractures خالص.
Okay. With C2 fractures, we have the odontoid fracture and the hangman's fracture. The odontoid fracture classified by Anderson and Alonso classification into the avulsion or of the tip of the odontoid, fracture waist of the odontoid, fracture base of the odontoid, 2% of type 1, 50 to 75% type 2, with the highest risk of non-union. Type A or type 1, the avulsion of the tip of the odontoid is treated conservatively unless it is part of a head injury. Type 3 in the collar or a halo vest with a non-union rate reaching 15%. In such case, you may need to fuse CO2 fusion. Type 2, which is the most mandatory for treatment, depends on the displacement and angulation. Up to 75% with initial displacement more than 6 millimeters, it reaches to or healed with non-union, and age more than 60 years old, also for non-union, delayed diagnosis for more than 3 weeks, angulation more than 10 degrees. All of these are up to non-union. Anterior odontoid screw for the displaced type 2, shallow type 3, and polytrauma patient unable to tolerate halo vest. Contraindications, which is more important, non-reducible odontoid fracture, the barrel chest, or very big abdomen or very big breast, associated tile injury, transverse atlantar ligament, or reverse obliquity or osteoporosis. Here some cases with odontoid fracture fixed with double screw. Here this paper, is there any need to fix odontoid fracture with non-union or not? When performing anterior odontoid screw in patients with type 2 or rostral shallow type 3 odontoid fractures, The displacement of the odontoid fracture fragment should be well reduced to the aligning position before screw insertion, and downward reduction should be achieved by perforation of the apical cortex of the odontoid during screw fixation, even if the surgery is delayed. Or the posterior C1-2 fusion. Fibrous non-union of odontoid fracture. Is it safe to accept non-operative management? Systematic review, and the conclusion is that you can accept the non-union of the fracture odontoid type 2, provided that dynamically stable, it has fibrous union, and there is no risk for other trauma. The Hangman's fracture, traumatic spondylolisthesis of the axis, actually هو أول ما توصف في الهانجنج تكنيك. الهانجنج تكنيك differs from the civil injuries. Judicial hanging differs from the civil injuries is that judicial hanging is hyper extension with distraction, but the civil injury is the reverse. It is hyperextension with compression. Hyperextension with compression. It is the second most common fracture of the axis, 25% of C2, and most common mechanism of the injury in road traffic accidents. Here is the windshield strike, where there is compression and axial compression and hyperextension, leading to fracture of the pars interarticularis or fracture of the facets themselves. Here, Levin and Edwards, which is the classical classification of type 1, is minimal displacement but with no angulation. Type 2 with angulation and more displacement. Type 3 with no displacement but with 2A with angulation, and type 4 with facet dislocation, which is the most unstable, with injury of the disc. Here is type 1 Hangman's fracture, 32 years female, treated conservatively. Here type 2 Hangman's fracture with halo vest treatment and residual instability, and treated with C1, C3 fusion. Here is a case with Hangman's fracture, but also with C2, 3 disc protrusion, leading to myelopathy, and it was treated anteriorly with anterior fixation, ACDF and fixation. كان في حالة طويلة. Thank you. Thank you.
Thank you, Dr. Ashraf, for the presentation. Anyone would like to ask? Thank you, Dr. Ashraf. There is no more questions.
I have a question, actually. When do you get this Jefferson fracture with displacement more than 5-7 millimeters of both sides, and you make sure that your transverse ligament is torn? How would you treat this?
First, we make some sort of traction.
Right.
Okay? If it reduces,
If it is not.
if it is not, actually for myself, I do occipital-cervical.
There is no method of putting screws in the lateral masses of C1 and then compression?
You compress
Side
it.
to side compression.
You compress it first. Yes.
How would you keep it?
You compress it first. You put the, if you could put the screws and the screws in C2,
C1.
C1 and C2, and then you make compression by transverse connector.
Right. Thank you very much.
شكرا.
In the case you treated anteriorly, because
Yes.
you find with the hangman a disc, do you find yourself in need to fix posteriorly, or is that sufficient?
No,
That is
no, it was sufficient. Yeah.
Okay, thank you.
Yeah.
Thank you. شكرا كراج ربي.
شكرا.
So the next speaker will be Dr. Muhammad Wafa. Dr. Wafa will give us a talk about C2, although it is a small bone, but it can showed itself with big problems.
Thank you, Mr. Chairman. He told me to get a lecture about C2 problems, and I never knew that I would be in a trauma session. So these things, it's a collection of problems which happen with C2 involved in these problems. I will not go into these considerations. I will go quickly regarding the anatomy and the types of ligaments and the range of motion. I was always under the impression that C1, C2 is important only in rotation, but actually it proved to be that in flexion extension it is much more than C0, C1, and also in lateral bending. It's much more important C1, C2 articulation. The nightmare of each surgery when we get in trying to get fixation around this area is the vertebral artery. I consider myself lucky that I had only 3 injuries of the vertebral arteries. You have to be very careful, and I'll show you this this picture actually. When you try to get your screw in C1, then you have to be very careful. This is the vertebral artery on the lateral side, and then you have the C2 root. Either you cut it or you displace it medially, and then you have the entry for C1. So you have to be very careful. If you do exposure of the posterior arch of C1, you have only 1 to 1.5 centimeters from the midline on both sides. Otherwise, you will hit the vertebral artery in the vertebral artery groove on the upper surface of C1. The overall incidence of iatrogenic vertebral artery injury is very low actually. It's 0.08, but it's mainly in C1, C2 posterior fixation. It's almost 1.5%. So you have to be very careful. When you look at these X-rays, actually, you know that all spine surgeons or cervical spine surgeons are crazy. Look at you are trying to put a screw in this area, in this very narrow pedicle, and the vertebral artery is just there, and you want to go home safely. No, you will not. You have to be very careful. So instability in my talk is not traumatic. Instability here, you can see this. This actually is a Down syndrome patient. He came to me, he's 25, 26, and with little or no trauma. They say no, there's no trauma. Again, that's a four years old female coming from Libya with Down syndrome, very active. And then the family noticed progressive quadriparesis. Look at the cord Malaysia spot at C1, C2 area, and you can see that the distance is not, the atlas dense interval is slightly enlarged, with neck pain, of course. So when I opened, I found actually the bones are too small, and the lateral masses in C1 and the trial to put a screw in C2 is very risky. So I resorted to this old technique, which I started with maybe 35 years ago, putting sublaminar wires in between C1 and C2 and good grafting, and this would do the trick. But if you get an older patient, 44 years old female, Down syndrome also, trauma, very little knock to the head, getting into the lift, and then she came with progressive quadriparesis, and you can see the distance C1, C2 is big, and you can see it here. So this actually case was done maybe 25 years ago. We did not do, by that time, it was not the custom to do C1, C2 screwing. So we used to do wires. But I put her in traction, and then when I tried to put sublaminar wires, I found that the posterior arch of C1 is incomplete. I was always under the impression that this is obliquely taken CT cut, but this was not true. So I resorted to occipitocervical fixation, and this was not well planned, and it's the only occipitocervical fusion I had with a broken metal. So I had to revise this, and I continued to see this patient for more than 20 years, and she unfortunately died soon, a few months ago. Again, female patient, 54 years old, progressive quadriparesis. Look at this. There's a trouble up here in C1, C2 area. And you cannot see what is this. But when you do the CT scan, you find that the odontoid is actually too small, maybe with os odontoidum, or maybe with trial of the body to fuse C1, C2. And you can see the exit of the cord here is very small. And you can see the kinking of the cord here. So, like all good orthopedic surgeons, we start always with traction, and it was not very useful. So we did anterior decompression with high retropharyngeal approach, and then posterior stabilization with these old plates. And I can still see this patient. She's living nearby, so you can see the difference between the orifice, the passage of the cord here, and preoperatively and postoperatively. But here is another form of instability. This is settling of the skull down, like in a rheumatoid patient with basilar invagination. Presentation is quadriparesis. You can see the cord compression at the foramen magnum. And what we did, actually, we did transoral decompression and posterior stabilization, as you can see here. Neoplastic, yes, it's a place for secondaries, that's a place for primaries. Look at this 62 years old patient, quadriparetic, and you can see the affection of C2 body, and proved to be undifferentiated round cell malignant infiltrate, which is proved to be later as a multiple myeloma. Secondary from breast cancer in C2. And this was the first presentation, actually, of the patient, of the breast cancer. She came with neck pain, and then we discovered this. So this is the CT scan. We did occipitocervical fusion, chemo and radiotherapy, and she was fine. Sometimes the pain continues. So I have this patient with the secondaries. First, he had end-stage liver disease. So he went in and to the hospital, and they found that there is a little hepatocellular carcinoma. Then he did a liver transplant. After 9 months, he came back with neck pain. And then he came actually with a picture like this. So we did a fixation, and the fixation was not good enough to control the pain. So we did transoral vertebroplasty to fill the defect in C2. Infections. It can be at C1, C2 at the skull base. And then, like this patient, we did anterior debridement to high retropharyngeal approach for evacuation of the abscess and cleaning and debridement, or it can be at C23, 47 years old male, neck pain, severe bilateral brachialgia. You can see that we did a posterior fixation and then anterior interbody grafting. Pathology is brucellosis, actually. Do you know what the antimicrobial needed for brucellosis? حد يعرف؟ Tetracycline? Yes. Yes, I was told then it's a doxycycline. اللي هو vibramycin. Vibramycin. This is one of the patients which I had a vertebral artery injury when I was putting one of these screws. So I put this short screw, the first one, I put the short screw, and then on the other side, I said enough to put like pars screw, not to go. This is common for brucellosis? Yeah, I have no. Right. And this is after 3 months. And I left the fractures to Professor Ashraf Ismail, odontoid fractures or hangman fractures. It's not my work. Thank you very much.
Thank you, Professor Rafa, for the presentation. Anyone would like to ask? Dr. Tariq?
Injury to the vertebral artery. Was the catastrophic bleeding at the time, or not?
Do you mean when you
Yes,
when
yes,
you're putting
yes.
the screws out?
And how did you manage the?
You drill, and then you look at the X-rays and you see the imaging transfer. You see that this is going well, and then you take your drill bit out, and then there is a
Gush.
of
Big gush. Okay.
arterial bleeding.
Okay.
So I'll put the screw, and then on the other side you have to be very careful, either to put it like lateral mass screw,
Okay.
or a par screw.
Okay.
So
Okay. And post-operative patient, no remarkable. Okay. Thank you.
Dr. Ashraf?
Dr. Wafa, when you feed in C2, okay, when you feel the medial side of the pedicle and medial side of the lamina and so, what about the lateral side, where the foramina transversaria are?
the problem actually usually the high riding vertebral artery. Yes, you feel the medial side, and then the direction is 25 degrees conversions, and 25 degrees, usually about 25 degrees up, but this I usually follow the imaging, it's fine.
Yeah.
The problem, there is nothing left.
Mhm.
The problem is high riding.
The high lateral up. Yeah.
While it is in the foramen transversus, you hit it.
Okay. Concerning the cases with the anterior subluxation or dislocation of C1, neglected cases, how you get up the C1?
With the wires, it's very easy. If you have C1, C2, and you put, say, C1, C2 screws, either when you put the rod,
You put the wires first.
or you put the
You put the wires first. Yeah, yeah. Thank you.
Thank you, Professor Wafa, for the presentation. So the last but not least for a speaker for this session, Professor Dr. Tariq Al-Fiqi will give us thoracolumbar trauma case scenario.
Oh, thank you very much, Mr. Chairman. So, are you sure you don't want to cancel my presentation because of the time?
No, we don't like to cancel it.
Thank you very much. I will present two very simple cases just for your opinion. Okay. I have nothing to disclose. So it's a female, 25 years old, involved in RTA. This is the X-ray that's showing something fractured in L 3. How can we proceed, Professor Khattab?
Neurologically free, yeah?
Free, nothing.
CT scan and
Isolated
MRI.
injury.
But it looks like A2 fracture. Huh?
Like A2 fracture, okay. So this is the CT scan?
It is A2 fracture.
Yes. And this is the axial one that proves that this is C2 fracture. How could you manage, Professor Khattab?
For such cases, I will do posterior fixation.
Okay.
One vertebra above, one vertebra below, and including the fractured vertebrae by post pedicles. And I closely follow up the patients. If the vertebral body didn't unite, that means with follow-up the disc will be disrupted. I can reopen the patient and do either TLIF from posterior, putting cage and bone graft, or go anterior, do partial corpectomy and put cage. Both techniques are valid in my hand.
Okay, thank you very much. So we are dealing with A2 fracture according to the most universally accepted classification, which is EO classification. The question is, A2 fracture is stable or not? Stable, not stable, semi-stable, is according to the literature. So A2 comes after A1 and A0, right? So it should be better than A2. A2 is better than L3, A3, and A4, according to the literature, according to, sorry, not the literature, according to the EO classification, right? Or there may be something wrong with the classification itself. So this is A2 fracture, split fracture. Management, Professor Khattab illustrated a very nice way of management, but in order to for Professor Khattab to like me, I should go to the literature to add some scientific points, to add systemic review, meta-analysis in order to be scientific. So he like me too much, okay? And ask, of course, we ask help from Allah, from God first, but I will ask the literature for helping me in treating A2 fractures, because still some people consider this fracture stable, and still some people consider A3 fracture even stable. So I'm afraid the answer is not actually, the literature didn't help me at all. There is nothing called management or scientific management of A2 fracture. So some people recommend surgery for some patients with A2 fractures only. I don't know what's the meaning of some patients. And still the current available literature have no clear evidence of fusion surgery versus non-fusion. The kyphosis, still the correlation between the kyphosis and outcome is not clear. This is according to the literature. Still, we can face some post-traumatic kyphosis from simple fracture, like A2 or A3. So, back to my case, this is the way I did it. Short intermediate fixation, one above, one below, and one inside, short screw inside the fracture site. It's okay for you?
I will put longer screws on the right side.
What you mean by longer screws?
In
It's
the
30,
index-
35.
In the
something.
index vertebrae, on the right side screw, the fractured vertebrae.
Yes, the fracture one, okay.
The right side screw, I will lose longer one.
A longer one.
It will not. It will
Okay.
not be a compression screw.
Okay.
But I will do it like this. I will go for longer one.
Okay.
If I will go for anterior, I will go from the left side and I will do only partial corpectomy. Longer screws may act, as Professor Hussein said, interfragmentary or something like this. We may ask also the panel, what do you think about the management, Dr. Wafa?
Okay.
This is very tricky fracture, actually. I had many of these who came back with a kyphotic deformity.
With kyphosis. Okay.
Yes, and I had to go anterior then to put them. So you have to be very careful with the screws. Either you put these short screws or only long ones on the right side, because we usually do the corpectomy from the left side. So you will not be facing the problem of a left screw. Yes, you do this and you wait and see. The other joints, I mean, if you go for longer fixation, it's very, I mean, the joints are very useful. I mean, 4, 5, and 1, 2, you need to keep them mobile.
Okay, sir.
We shouldn't delay our intervention to reconstruct the anterior column. If you feel the anterior column is comminuted, so from the beginning you have to deal with the anterior column reconstruction by graft. Because if you do it in that short timely, it will collapse.
Sir, this is the anterior column. It's not very much comminuted.
Yes, but just
There is no good definition for the comminution, but
just posterior to the anterior cortex, you
Okay.
find the comminution too much.
okay.
So it is the edge of the vertebral edge. But
Okay.
it is the piece behind. So if a situation like this, I would recommend the anterior column reconstruction
Okay.
very early.
Okay, from the start.
Yes.
So you want me to add one more stage, anterior,
Yes, please.
anterior.
Yes, because whatever you are doing metallurgy wise behind, it will collapse anterior.
So I'm going to open the abdomen for the patient for additional.
You can go even posterolateral or go open. Why not to?
Okay.
You can open now by different.
Professor
healing
Khattab, you don't
ways.
like me to open the abdomen of the patient?
No, I will not open the abdomen for this patient. I will wait and closely follow up. And I will tell you something, Professor Tariq. I had one young female, 19, 18 years old, teenagers, and she presented to me with A2 fracture, and I fixed her percutaneously. And after 8 months, she started to run, do everything. She presented to me with broken screw after percutaneous fixation.
Okay.
So I told her, now it is time to go anterior and reconstruct the anterior column. And I did MRI and I found that the discs are healthy. And in the CT scan, the bone is fused. In the E2, it is fused. So I changed my decision and I told her, we can only remove the construct and look how you will feel with follow-up. If you need to refix and do anterior, we'll do. If there is no complaint, that's only we will remove the construct because the friction is the cause of pain. And I removed the construct after 8 months, and she is doing fine now for 5 months.
How about the sagittal profile? No,
a little
no
bit loss of kyphosis at this segment, but clinically, a loss of lordose kyphosis.
Yes,
I mean.
clinically it's
But
fine.
clinically, she is very fine and has nothing to complain.
Okay.
Yeah, clinically, as young, have good muscle, active, she will be fine for 20 years to come. But we are dealing with reconstruction. If the anterior column is defectively, clearly, I mean destruction in the middle column towards the anterior column. Whatever you put through screws, you will find after, say, 1 year, 6 months, the collapse comes. She will live like this with kyphosis, and she will suffer after 20 years. So
Yes.
in the beginning,
Yes.
if her anterior column insult, you have to repair the anterior.
Okay. So I follow the suggestion of Professor Meziad. I add one more abdominal surgery for her extraperitoneal, and I'm satisfied, patient satisfied, it's okay. So you don't consider this as an overtreatment for E2 fracture?
No,
Okay, thank you
not
very
at
much, sir. I'm pleased to give you the second one also. This female, 41 years, neglected L3 fracture. Still in our country, we see not only facet dislocation neglected, but also lumbar fracture neglected. It's neglected, of course, not from the patient, but from the treating doctor, okay? This is this is the fracture. Professor Khattab, please, would you treat this patient for me?
يعني انت خلاص بقى حلتها يعني. Neglected.
No, neglected, sir. Neglected, sir. 5 months, sir.
5 months.
5
5
months.
شهور يا بيه. 5 شهور.
Yes.
Full program.
Okay. Some kyphoscoliosis. This is the CT. So E2 fracture is not a simple fracture as some people think, and I'm one of them. It is very dangerous, and I don't know why the AO put A2 fracture before even A3 fracture. It's completely split with much kyphosis, with scoliosis, and this fracture is not going to unite with progressive kyphosis. So the first way is to achieve stability, to treat the deformity, and to reconstruct the anterior column. It was not difficult to correct the kyphosis through two simple osteotomies. Ponte, just Ponte, 2 Ponte osteotomies. 1 week later, I opened the abdomen for anterior column reconstruction. So I think A2 fracture is a dangerous fracture and should never be under treated. Thank you very much.
But for the last case, I will shorten the construct, Dr. Tariq.
You will shorten the construct.
Yes.
Okay.
But very, very nice.
Okay,
case.
thank you.
So thank you so much for your attendance. And this is the conclusion for the session. وناخد صورة جماعية بقى. هو الأجانب انسحبوا خلاص. ماشي.